Hi, my name is Megan McCarthy. I'm one of the PGY1 pharmacy residents at Moses Cone Hospital. Today I'm going to be talking to you about beta-lactams. This presentation was actually put together by Emily Stewart. She was one of the PGY1 pharmacy residents a couple years ago. She's now our antimicrobial stewardship pharmacist. So the purpose of the following PowerPoints will be to go through the different classes of antibiotics. So some IV drugs have been included just to make you aware of them, but for the purpose of these, we'll be mostly spending a majority of our time on the oral formulations. So the first class that we're going to go through is one of the oldest classes. It's called the beta-lactams, and it's named for their chemical structure. So this class includes penicillins, cephalosporins, and carbapenems. These agents all work on the cell wall. So there are many drugs in the beta-lactam class alone. The best way to keep them straight is to group them into classes and learn the characteristics of each class. But lucky for us, they all share a few things in common. So the mechanism of action is that they bind and inhibit the PBP transpeptidases or penicillin binding proteins in the bacterial cell wall, which lead to cell lysis and death. They cover gram-positive, gram-negative, and anaerobics based on the generation of beta-lactam. However, they have no atypical coverage, and this is because they do not have a cell wall. So when we're looking at penicillin, cephalosporins, carbapenems, and aztreonam, one of the best agents to use in a true penicillin allergy patient would be aztreonam. So these are a natural penicillin, so Pen-G and Pen-V. They have a good spectrum of activity, so group A strep was one of the more common ones. However, staff quickly developed a resistance against these penicillins, so it's not a great empiric drug at this point. So the clinical uses would mostly be for strep, syphilis, and then Neisseria. When we're looking at anti-staphylococcal penicillins, this would be like dicloxacillin, nafcillin, oxacillin, and then methicillin. So these really just have gram-positive, so MSSA. They do not have MRSA coverage or methicillin resistance. Some things to think about these is in acute interstitial nephritis, so AIN. These would be some of the reasons that methicillin is no longer manufactured is because of the incidence of this acute interstitial nephritis. So these anti-staphylococcal penicillins are good for staff because they do have some protection against penicillinases. Aminopenicillins, these actually don't have any coverage against Staph aureus, so they do have increased resistance to penicillinase producing E. coli and H. influenza. The drug of choice in ampicillin susceptible enterococcal infections. So some of the clinical uses would be otitis media, strep, and then, like I said, the sensitive enterococcus infections. With aminopenicillins and beta-lactamase inhibitors, this would be our augmentin or our unison. So the spectrum of activity for this would also include gram-positives, gram-negatives, plus the anaerobes. So with the clavulanate and then sulbactams, the beta-lactamase portion doesn't have much of an antimicrobial activity by itself. It just frees up the beta-lactam to kill the organism. So the clinical use for this would be for mixed aerobe and anaerobe infections, so ulcers, abdominal infections, aspiration pneumonia, and wound infections. With our extended spectrum penicillins, these would be Zosyn or Tycar with clavinic acid. So these are very similar to the previous slide with the additional coverage of Pseudomonas. So IV-only medications used mostly in hospital, but you may have some patients on outpatient IV antibiotics, so that's why I included those here. So the spectrum of activity would still be gram-positives, gram-negatives with that Pseudomonas bacteria coverage, and then anaerobes. With the beta-lactam, the cephalosporin class, so better activity against gram-positive, the MRSA, so the first generation, where as you go throughout the generations and you accumulate better gram-negative coverage. So there are lots and lots of cephalosporins available. The list can seem a little bit overwhelming, and you eventually be able to identify which agents make sense to use and when. One key thing to remember is the only generation that has activity against MRSA is the 5th generation. So this would be ceftaraline. With our 1st generation cephalosporins, these would be cephalexin or Keflex, and then also cefazolin or Ancef. So cefazolin is our IV option, while Keflex is our oral, so you can do capsules, tablets, and suspensions. These often can also treat UTIs, and so the clinical use we would use these in is for MSSA infections, skin and soft tissue infections, UTIs, and then surgical prophylaxis. You can use these in penicillin allergic patients if they've tolerated it before or if they have a low suspicion for a true anaphylactic reaction. The cross-reactivity is less than 3% for true allergic reactions. However, these are not active against Enterococcus, so it is something to keep in mind. With our 2nd generation cephalosporins, some of the names are listed here for you. So Seclorceftil, Ceftin, and then Cefoxitin. So they break down which are the oral and which are IV formulations. So these do have less activity against gram-positive, but like we mentioned previously, they do have more activity against gram-negatives. So the clinical uses for this would be upper and lower respiratory tract infections. These do cover strep pneumo and E. coli. And then they do have more negative coverage than the 1st generations. This would be like H. flu. For our 3rd generation cephalosporins, these are listed here for you as well. So these still have some gram-positive coverage, but they also have the additional gram-negative. Ceftazidime is a little bit unique, however, because it does have the gram-negative and the Pseudomonas coverage. So these can be used for UTIs, skin and soft tissue infections, etc. With our 4th generation cephalosporins, this would just be Cefepime. So the spectrum is more gram-positive, gram-negative, also including Pseudomonas. This is IV only, so this is usually used as an empiric agent first when we're concerned for Pseudomonas, and then we can back down to more narrowed coverage as we find out what bug is specifically causing it. And then last but not least, our 5th generation cephalosporin is ceftaraline. So this one does have more of a gram-positive than the 3rd and 4th generation. It does include MRSA and then Enterococcus, but the gram-negative piece is pretty similar to the 3rd generation ceftriaxone. So we can use this in skin and soft tissue infections and then also CAP. However, it is pretty expensive, so it's generally used as a backup after treatment failure, and it does not cover Pseudomonas. Now moving on to the carbapenems, so this would be like imipenem, meropenem, doripenem, and ertapenem. A lot of these agents are either IV or IM, so that limits how much we're really using them on an outpatient standpoint, but it's still good to keep in mind because you might see some patients that are going home on IV antibiotics. So carbapenems do not cover MRSA or atypicals. Imipenem actually has the highest risk of seizures among the carbapenems, so that's something to keep in mind. If we do have a patient who does have a history of seizures, we would want to avoid that one. So these do have gram-positive coverage, gram-negatives, including Pseudomonas and anaerobes. And then we can use these usually for empiric agents, and they're especially useful when we have multi-drug resistant organisms and we've exhausted a lot of the other options that we have available. For the monobacteriums, this would be Estrianam. This covers only gram-negative organisms, including Pseudomonas. So this is an alternative when we have that true penicillin allergy. However, because it only covers gram-negatives, we don't want to be using this for gram-positive infections. So this is really to just be used for broad-spectrum IV agents for gram-negative coverage. Moving on to common adverse effects with beta-lactams. So the biggest things that we're going to be concerned with is GI intolerance, hypersensitivity reactions, and then the risk of seizures, which I mentioned previously that this is more with carbapenems and especially imipenem. So allergic reactions are the most important toxicity of beta-lactams. So we want to make sure we ask the appropriate questions. So what specific drug was your allergy to? Try to be specific rather than just saying penicillins. You would want to ask, do you remember what your reaction was? So if they just had, hives, or if they had like a bronchospasm or angioedema, you would want to know what happened when they had it. So were they intubated? How long after taking the drug did it happen? What did you and your physician do? Did you have to go to the emergency room? Did you just stop taking it? And then what other antibiotics have you taken since then? So have they tried other cephalosporins and tolerated those instead? So most patients, which is about 90% of patients with a penicillin allergy, don't actually have a true allergic reaction when you give them an immunologic challenge. So a detailed history is required to determine the nature of the allergy and the risk of exposure to other lactams. You can use a penicillin skin testing, but this is just kind of dependent on the institution or the clinic that you're working with, and that will actually provide a documented proof of a true allergy. Another thing to note as far as the GI intolerance is that many penicillins are relatively poorly absorbed, so that's what they usually tend to stay in the gut and cause the diarrhea with that. So that's kind of the reason why that they have some of those GI intolerances. So when we're trying to determine with a patient who has a penicillin allergy listed, these are kind of the things that we would want to do. Type 1 reactions are the most concerning. So the clinical manifestation would be like anaphylaxis, so we would have that airway swelling, bronchospasms, hypotension, or angioedema, and usually it's between minutes and hours after the dose. This is a life-threatening emergency, and so we would want to give them epinephrine, antihistamine, steroids, and then send them to the ED for evaluation. We wouldn't want to re-challenge this, so avoid using any beta-lactam except for aztreonam because we know that that is okay to give if they have a true penicillin allergy. And then there's a potential that we could desensitize them if there was a compelling need, but there are other agents available that we could potentially use instead. So for this case, we have a 15-year-old female who presents to the clinic with a chief complaint of sore throat and fever. Her vital signs, her temperature max was at 100.5 degrees Fahrenheit. Her weight is 50 kilos. Physical exam was really only notable for redness of her tonsils, and she does have a penicillin allergy listed from when she was 4 years old, and the reaction was itching. So out of these agents, we have PenVK, Zosyn, Ceftonir, and Ertapenem. So which agent would we think about using? So first things first, we want to know about the allergies. So the reaction was itching. So we could clarify this and ask what happened. Diagnosis would be like a rapid stress test and culture. So with A, or PenVK, this would be a first-line treatment for strep throat, but this may not be the best option in penicillin allergic patients. With B, for Zosyn, it's IV only, so we wouldn't really need that broad coverage for this patient. Option C, this is a good option for penicillin allergy patients. However, and then with D, Ertapenem, that would be an IV only empiric agent, so C would be the best answer here.